Hi, everyone. Welcome to Mount Carmel's Wellness Webinar. I'm Diana, a Senior Marketing Specialist here at Mount Carmel, and today we're talking menopause. The conversation surrounding menopause is everywhere. We hear it on the news, social media, celebrity talk shows, and podcasts. Menopause is something that, if we live long enough, we'll all experience. With so much information out there, it's important to know the facts. At Mount Carmel, we believe it's important to have credible information from experts to give you the care you need, which is why I'm so thrilled to have Dr. Nicole Zakowski joining us today and talking to us about what menopause really is, its symptoms, and solutions to help you through it. Dr. Zakowski is a board-certified obstetrics and gynecology provider and practices at our Mount Carmel OBGYN Easton location. If at any time you have questions for her, please enter it in the Q&A section and we'll save some time at the end to answer them for you. Dr. Zakowski, thank you so much for being here. The floor is yours.
Thank you. Thank you, Diana. And hello and welcome, everybody. Thank you for sharing your busy Friday afternoons to talk about a very important conversation and topic, menopause. Let's start with the basics. The definition of menopause is a point in time when a person has gone 12 consecutive months without a menstrual period. What a simple definition for such a complex conversation, a complex journey. I really like to call it more of a menopausal journey with stages and everything. Everybody's journey is very individualized with timing, severity, and symptoms. So let's talk a little bit about these stages of menopause. So the first stage of menopause is perimenopause. I think this is a little bit less understood. It can start occurring as early as age 40 to about 55. This is a time when your estrogen and progesterone levels are starting to fluctuate and starting to lower. It usually happens about 3 to 5 years before menopause, and you can start noticing some irregular menses, mood changes, hot flashes, start to have a little vaginal dryness, some sleeping disorders, and also weight changes. Of course, we discussed menopause. That's 12 months without a menstrual period, and it usually averages around age 51. Once you pass this, after those 12 months, you're now in post-menopause. You start to lessen your symptoms, usually and hopefully cessation of your symptoms, but it usually lasts around 3 years. Unfortunately, there are some patients that it can last up into their 60s and 70s. At this time, with the lessening and no longer making estrogen, women do start to experience increasing vaginal discomfort. So let's talk about those menopausal symptoms. So the number one menopausal symptom is hot flashes. Approximately 50% of women report that they have these. They are a sudden sensation of extreme heat in your upper body. They last about 1 to 5 minutes. Some women have them very sporadic. Some women have them hourly. This peaks about 1 year after menopause, and they actually can last up to 4 to 10 years. Another thing, the second most common, is vaginal atrophy. This is where there's the thinning of the tissues in the vagina. Women, when they start noticing this, can notice a little bit more dryness, itching, painful sex. They also can have increased yeast infections or bacterial infections, and even increased bladder infections. Other menopausal symptoms, sleeping. Women start being unable to go to sleep, or if they awaken early in that 2 o'clock morning, they can't go back to sleep. They start noticing mood changes, depression, anxiety, forgetfulness. We all hear about the brain fog, joint aches and pains, and some women can even have a little bit of an irregular heartbeat. So what can we do about menopause? Well, let's talk about the menopausal treatments. Let's first talk about things that you can do at home. These are diet and lifestyle changes. We found that hot flashes can be brought on by certain things in your diet. So try to avoid those: caffeine, alcohol, spicy foods, even a very sugary meal or a full fat meal too. Eat a low-fat diet. Not only do we have hot flashes, but we start to see increase in heart disease and changes in lipids. So eat that low-fat diet to keep that heart healthy. Calcium and vitamin D supplementation. We stop making bone at age 28. The biggest time when we start losing bone mass is after menopause. So start that calcium and vitamin D supplementation. General exercise, keep that heart healthy. keep, the hot flashes away, and even things called Kegel exercise. Those keep your core tight and actually decrease your risk of having bladder leakage. So when you are having those hot flashes, start some slow, deep breathing exercises. Wear a lot of layers. Try yoga, Tai Chi, and meditation. And of course, with that vaginal thinning, continue to have sex. If it is starting to become a little bit drier and more discomfort, you can start using lubricants. Natural water-based or silicone lubricants are fine. There's also vaginal moisturizers on the market too. Are you seeing in the marketplaces and on Amazon and on the internet a lot of complementary botanical and natural products? Now, these products, they're not maintained by the FDA. That's not FDA's role. But there are some studies showing some natural supplements, ginkgo biloba, ginseng, St. John's wort. Really, no studies have shown any big benefit. Phytoestrogens, we're finding there are some natural estrogens and some plant-based foods and food products. Again, not a lot of studies showing benefit for hot flashes. Chinese herbal treatments, I did find some studies. There are some treatments that have been shown to help hot flashes, and actually adding acupuncture in one study showed a definite benefit. Black cohosh, we see it. It's over the counter. We can see it in our Meyer pharmacy. There has been possibly some benefit. There are not a lot of studies, and this is something really we should look into. All right, let's talk about systemic hormonal therapy. This is the classic hormone replacement therapy that everyone talks about. It's Premarin, it's Combipatch, it's Prempro. There are two forms. You have estrogen only, or you have combined estrogen and progesterone. We have to use combined estrogen and progesterone when you still have your uterus. If we just use estrogen alone systemically, you could have a higher risk of having uterine cancer. There are some side effects: breast tenderness, vaginal bleeding, bloating. There's some benefits in the study, some decreased risk of colon cancer and decreased risk of fracture. Now, of course, this is very controversial, the HRT. In the 90s, in the 80s, most women were on HRT, but in 2002, that stopped everything. There was something called the WHI initiative. At this time, they were actually only studying heart disease and if that hormone replacement therapy benefited women if they were taking it. This study had women in age 50 to 77. There were starts with women, they started later on in their 60s and 70s. And at that time, they found in the combination therapy that there were a slight increase of stroke, clots, heart disease, breast cancer. So they even stopped the study and did not complete it. They felt, though, that they saw the estrogen only was a little bit safer. Now, looking back years later, we're thinking, well, wait a second, this study was not looking at those women who we really should be using these hormone replacement therapies, young, early menopause women in their early 50s. So now ACOG has kind of backtracked and said, maybe we blew this whole thing, and that really we can use these hormone replacement therapy in appropriate candidates if at the lowest dose for the shortest time possible. They do, though, recommend really only to use this for hot flashes, moderate to severe, because now we have other things, bone health, things to lower your cholesterol. We have other medications that seem to be safer. I just like to note one other time, the estrogen only study, they did not stop or say that we should stop that. So we're thinking that possibly the increased risk was the progesterone. So for women who don't want systemic hormones and their biggest thing is their vaginal symptoms, or they've stopped having hot flashes, we can start using a safer product. This is targeted hormonal therapy. There's vaginal estrogen. It's in a cream, ring, or tablet form that you place in the vagina. This is much safer. It's very localized. So the levels of estrogen are really not, if very little increased in the blood. You do not need progesterone if you still have a uterus. There also is another vaginal suppository. It's called DHEA. This is a hormone. It's up in the pathway. It can be converted to estrogen. We think it's a little bit safer, though we still don't recommend it in women who have had breast cancer, just because we don't know exactly how much of that is converted to estrogen. For people who don't want to use anything in the vagina, there is a pill option. It's a daily pill. It's an estrogen agonist antagonist. This is not estrogen. These are actually smart drugs that go to the receptors of the glands that have estrogen receptors. It's actually positive in some organs and negative in opposite organs. You see tamoxifen, it's negative in the breast. That's one of these estrogen agonist antagonists. We use osfine or osfina. This is actually positive in the vagina, negative in the uterus, negative in the breast. Side effects for the osfina are hot flashes. So for women who are having that, it maybe isn't the best option. If you're thinking, wow, if you can use estrogen, why can't you just use progesterone only? If you remember back when I talked about the combined estrogen progesterone, we were thinking the progesterone really might have caused that increased risk of all those, the stroke, the clots, and the breast cancer. Therefore, we don't really use it as a first-line therapy alone. Let's talk testosterone. So testosterone is not FDA approved. There used to be a pill, and we used to think that it did benefit for treating hot flashes. We're seeing that it might not. There's some mixed studies, but it used to be in a pill. It was called Estrogen, but that's no longer on the market. We have seen that it can improve sexual function. So really what we just say is you should discuss this with your physician and talk about prescribing for it. What we worry about, though, with testosterone is the side effects that can sometimes be irreversible if you have too much is excess hair growth, acne, and changes in your lipids. Menopausal treatments, again, let's talk about bioidentical hormones. That's a very hot topic too. Let's define it. Bioidentical hormones are plant-derived. They are structurally identical or chemically similar to those made in the body. What women might not know is there are some commercially available prescribed products that are approved by the FDA. This is your estradiol, which is estrase, or your estrogenide progesterone, which is prometrium. You know, these are a dose that we know the side effects, they've been rigorously tested. Now there are compounded formulations. You know, we worry a little bit about this. The doses are adjusted per the patient. There can be overdosing and underdosing. But, you know, there is some room for compounded formulations and compounding pharmacies with our patients. You know, sometimes a patient cannot tolerate the fillers or what's in the commercially available. They're allergic to something. They need a different transfer system. You know, they can't just take pills, or the patches are irritating. Or sometimes I just can't get women comfortable and have symptom reliefs. So there is an avenue when I do send people to a compounding pharmacy. So let's wrap this up, kind of talking a little bit about non-hormonal medications. Some are FDA approved, some are not. The newest medication, which is very exciting for us, especially with our patients who definitely cannot have hormones. Those are our breast cancer survivors, our women with significant cardiovascular disease, or women with clot history. There's something new called Veozah. So Veozah actually works in the chemicals in your brain. There is a gland called the hypopituitary gland, which actually we find regulates temperature in the body, and this actually works on that. I have used it on some patients, and it's very promising. You know, there are a few side effects. The severe thing is that they can cause increased in your liver enzymes. So we just have to do a couple of tests to make sure that your liver enzymes are good. So test before we do it at month 3, month 6, and month 9. We have an FDA approved antidepressant. We found a side effect of an antidepressant actually is to help hot flashes. The one that is on the market is paroxetine, and it is FDA approved. You know, they got FDA approved because they did the studies. So we can really probably use most SSRIs, you know, your Lexapros, your Celexas, and things like that in lower doses to see if you can get comfortable. Non-FDA approved things that some doctors use. We use a lot of things, not a lot of things, but we can use some things off-label to help those patients, especially those patients who are suffering who cannot have the hormonal replacement therapy. Clonidine is a high blood pressure medication, a very older high blood pressure medication. It has been shown in studies to show hot flashes, but we worry about, you know, people with lower blood pressure. You know, they might have some drowsiness and some dizziness. So too with gabapentin. If you've ever seen gabapentin, is an anticonvulsant, but a lot of people use it for chronic pain, sleeping, and everything. So the studies have shown it does help hot flashes. You know, we worry about that drowsiness and somnolence and dizziness again. So here are some therapies and some brief topics that we are discussing. I hope that this has given you some information so that you can go back to your doctor and discuss your pathway, your treatments, what symptoms are affecting your life. If you don't have a women's health expert, please feel free to schedule a women's health appointment. We have offices in Easton, Grove City, London, and Pataskala. There's the number that you can call. Thank you guys very much for listening to my talk. Any questions?
Right. I know I see a couple questions in the Q&A section. So just a reminder, if you have any questions, just drop them on there and we will answer them. First question, do you recommend Veoza and Elinzane for menopause? And are you taking new patients?
What was the second one?
I'm going to spell it out because maybe
Okay.
I'm pronouncing it wrong. It's Elinzane.
I don't know that one, but yes, I'm recommending Veoza. I'll have to look up the other one. I don't know that one. But yes, I really like the Veoza, I mean, I've seen some really great results. And, there are a lot of women, they're hesitant to be on hormones. They see their risk and they just don't want to take that risk. There are, like I said, there are some women who have a history of breast cancer. They've had strokes. They have heart disease, and the doctors say, no, you can't be on everything. And I see them suffering. I mean, they're having hot flashes every day. They can't sleep. They're waking up drenched. And I've seen some great results. It's a new drug. So obviously we're being cautious with the liver enzymes. I'm sure eventually when we get a lot more data and everything, that might go the wayside. But yes, I really do like that. And yes, I am taking new patients. Both I have a day in Pataskala and my main office is in Easton. So.
Great. Then I'm going to go ahead and go back to the QR code in case anybody wants to scan it. You'll be able to go online and schedule an appointment there. Now I see we're getting lots of questions. That's exciting to see. So go ahead and keep reading them. Question is, why does it cause body odor?
As body, I have never heard that from my patients. That hormones cause, or are you saying menopause? I mean, if you're saying menopause, yeah, some women do complain of some body odor, and I think it's just the changing of the hormones and everything, and in glands. I mean, glands are very hormone mediated, so you're seeing an absence of the estrogen and the progesterone, and probably see that. So, yeah.
Another question is, what if you cannot have estrogen? Previous DVT, so I cannot have this.
Yes, so that's why I'm so excited about the Veoza. So that is non-hormonal. That is safe in those who cannot have estrogen. So I'm really excited about that. So you can have that. For hot flashes, you can have the SSRIs too. So the one that's a very low dose of that, and even those off-label ones. But now that we have two very good options, I'm really pleased, especially for those who just can't take the risk.
Next question. I am 46 and have regular hot flashes once every couple of hours. Would I be a good candidate for estrogen hormone replacement? And also, how does HRT differ from birth control?
That is a great option. So if you're still having regular periods, probably the hormone replacement therapy isn't for you because it probably make more irregular periods. So that's kind of where we have to tease it out. So you're probably in that perimenopausal stage. And who thinks you're having regular periods or even just periods and you're still having, you're having hot flashes like what we think for menopausal women. So normally for women who are still having periods but are having those symptoms, I'll put them on a very low dose birth control pill. But then we have to tease out when you do become menopausal, because the difference between systemic hormone replacement therapy and birth control is hormone replacement therapy is 1/5 the dose of combined birth control pills. And think about if we have risk with this, just that 1/5, if you're in menopause, we really have to get you down to that 1/5 and not continue beyond on birth control pills. So normally what I do is I have a good conversation with women, when they get to about that 51 years of age, when it's that average, I tell them, why don't you go off your birth control pills? Let's see what happens. If you continue to have periods, we'll stay on it. If you stop, then we'll go on to the hormone replacement therapy.
Great. Next question. I've heard that olive oil and coconut oil can be used for vaginal dryness. Do you have any thoughts?
No, I love that. It's I talk about that with my patients. My patients use it. It's very natural and everything. It doesn't have those dyes. I'm a big proponent for it. So yes, those are definitely fine to use. I don't think that they cause any increased infections or anything like that. So.
Next question is, hi, Dr. Z. Can you discuss the difference in normal hormone levels versus optimal levels? For example, my testosterone is at 11, which is very low, but still falls into normal range.
So this is a very big hot topic now, hormone levels. So what do we do with hormone levels? So how we're taught is hormone levels for every woman is different. And every woman, if we sat 12 in the room, could have the same hormone levels, but react to them differently. So really, we go on symptoms. So, your testosterone level, you might have big issues with libido, energy, and everything like that, whereas someone else, fine. So really, we're not really stuck to these hormone levels. I know in compounding pharmacies, they do like to do that and kind of taper it. But really for us, we go towards how are your symptoms being controlled? If they're not, then we'll go up. If they are, we'll stay at that nice low dose.
The next question is, I am a breast cancer survivor. I have had a full hysterectomy. I experienced vaginal atrophy. I cannot take hormones for vaginal dryness. I have looked in the Mona Lisa treatment, and are there any other non-hormonal treatments that you can recommend for VA?
So that's a difficult one too. There are some natural things. There's vitamin E. There is a natural company that's now looking into a little more of hyaluronic acid. The Mona Lisa, is a big hot thing, but ACOG, our college has never really been a proponent of it. So, I'd be leery of that, but really it's going to be those natural ones. But you're right, that one, we still need to do some more research. So, some women with very, 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 very remote breast cancer, can be put on the vaginal estrogen, but that's kind of a risk and a big discussion to talk with your oncologist. But a lot really like to stay away from it because we don't want to increase your risk, after your successful treatment. So I would probably look at more the natural things. So some of the compounding pharmacies make a natural kind of vaginal suppository. And there's even a new compounding pharmacy online that does something, and they're looking into hyaluronic acid and things like that, more natural.
What can you do for breast tenderness?
That's a hard one too. First off, things that make breast tender, caffeine, chocolate, things like that, start trying to eliminate that from the diet. If you can't, or you're not a person who does that, you can try some natural things. That's really what we have. Vitamin E supplementation we've shown to help. And then primrose oil, midnight primrose oil also is another supplementation that we're using for breast tenderness.
Next question, are hot flashes and night sweats the same thing physiologically?
Yes. And I should have said, I was going to say that in my slide, but I forgot. Yes, they are. And it's funny. It seems when women have night sweats, they have night sweats. And then when women have hot flashes, they only have hot flashes. It seems to select for some reason. But yes, they are exactly the same. It's that organ in the brain with the heat regulation. We think it's those hormones that cause it.
Are you seeing the average age of menopause increasing? I'm 56, still peri.
No, I haven't. I think it's still that way, but it's a curve. So there are some women, I do have some women in my practice that are just keep going on. There are some things that cause women to go a little bit farther, but no, I really haven't seen. I still see that around that like 51, 52.
What can be done to treat fatigue?
I know fatigue is hard. I mean, it's just good lifestyle habits, get to rest, make your bedroom, try to get good 8 hours of sleep, exercise regimen, take your vitamins and your supplements and everything. So
The next question is, I've had a hysterectomy, but still have my ovaries. Had an IUD prior, so I don't know when my period stopped.
Okay.
Having hot flashes now, what do you recommend?
So I would look at your age and see, I think this is the time when hormone testing is ideal. So, you go to your doctor, you get your estrogen, your progesterone, and your estrogen, your FSH, and your LH, and we can see if you're in that menopausal range. But, lowest dose possible. So I would definitely offer you, if you do have a good risk profile and you're up to it, I would offer estrogen.
The next question, what constitutes a period when you are starting the menopause clock? What if it's just spotting?
I would start it over again. So that would constitute bleeding or a period. So yeah, and you have that irregularness, but I would start it all over again. So
Next question, what can we do about bursitis and joint pain? Hormonal, not arthritis.
bursitis and joint pain. Well, I mean, there are some natural supplements, obviously, oh gosh, the chondroitin sulfate and things. Good exercise. I think they're now finding studies that cardiovascular exercise maybe might not be the best for us, that as we're entering the perimenopause and menopause, really we should be doing more weight training and strength training and things like that. Obviously, continuing to exercise and everything, and go from there. And then even looking at your diet and see if, are you eating inflammatory foods or things like that, and try to kind of tear those down and see, maybe that's causing that inflammation.
The next question, I have, and I might butcher this, I'm sorry. I have factor V Laden.
Factor V line, yes.
Many options are prohibited. Any suggestions?
So again, that last cover slip you're the perfect person for that. I mean, there is the Veoza now. You are definitely a candidate for that. You're definitely a candidate for the antidepressants. And then if you want to, I mean, if it's really affecting your life, you can even look into those off-label, gabapentin and clonidine. So, but yeah, like I said, I'm really excited about the Veoza because, you do feel for your patients who really just can't be on the hormone replacement therapy.
The next question we have is, what if you're producing too much estrogen and having periods again at 62 years old?
You should not have periods at 62, so you should definitely get an evaluation. That is very abnormal, and it would be very abnormal for you to have estrogen levels. So I think you need a evaluation. So in something, unless obviously if you're on some systemic hormone, or if you're on some compounding hormone or something like that, a reason why you really should not be making estrogen. So I think that needs prompt evaluation.
The next question is, my symptoms are mild. Should I start some kind of intervention?
It's up to you. If it's affecting your life, then definitely, and you want something. If they're mild and you're fine, and you can do maybe just some of those lifestyle and diet changes, that's great. I don't think that you're missing out if you don't have the hormones. I mean, there are some risks, so really we say more moderate to severe. So yeah, as long as you're taking your vitamins, taking your calcium, and you're doing okay, you're doing your layers, I think it's okay. I don't think every woman needs to be on hormones.
The next question is, what was the name of the antidepressant that was helpful for menopause? I didn't
Yes.
catch it.
It is, sorry, let me look it up again because it is, I don't know why I'm blanking. I'm having the brain fog that they talk about. So it is, I believe it is paroxetine, but let me double check that, which is Paxil. But there's another name for it. So, but yes, it's a low dose of paroxetine. Yeah, that's right. It's a low dose of paroxetine. So.
And if you joined a little late, we will be adding this to our website at Mount Carmel Health. So you are more than welcome to go back in and see this webinar and the past one. The next question is, what can we take for joint pain? I have a terrible joint pain, have been tested for arthritis and thyroid. No issues, so it has to be hormones. Also, anything we can do about the brain fog?
Yeah, I know. It's hard. I mean, you know, if the joint pain is debilitating, I mean, you can talk with your physician to see if you want to be started on some estrogen and progesterone and systemic therapy. You know, you'll have to see your age, you know, when you went through menopause, your risk factors and everything like that. I think we talked about some supplements, you know, continue to exercise. If it's hard to exercise with the joint pain, pool therapy and everything like that, kind of getting those moving and everything. So brain fog, again, the hormones can help, but I mean, there really isn't too much out there for the brain fog. I guess the adage is you've just got to use it, keep using that brain and everything. So
what is your best suggestion for weight gain in menopause?
So weight gain in menopause, it is definitely a thing. Your metabolism definitely changes and where the deposits of fat change too. So I really think you need your you know, exercise routine. You know, you get that exercise in more days than not, 30 minutes. As I suggested, you know, maybe not as much cardio. Cardio and more of the Pilates and the you know, the strength training and everything like that. And then of course looking at your diet, you know, try to look and see how much carbohydrates, you know, now with your metabolism decreasing, portion control and everything like that. So
The next question is, are there over-the-counter supplements I can take for hot flashes? And how long do they last? It's been 5 years for me.
so everybody is different with their hot flashes. I wish we knew, and I wish we had tests to see. The average of after menopause for women is about 3 years, but I see it up to 10 years. So, like I said, they peak about 1 year into menopause. You know, like I said, I think the most kind of the ones that are more we haven't done a lot of studies is the black cohosh. So you can definitely use that for your hot flashes to see if that work. A lot of the other things, I mean, we're thinking now is more just placebo effect, but if it works, you know, you might just try it. So those are the over-the-counter supplements.
Someone is asking if this video will be sent out because we missed a couple points. Yes, you'll receive an email within 24 hours with a link to the video, so you'll be able to see it there. The next question is, do you have to have a yearly exam if you had a hysterectomy?
So that's a good question. You know, we are still saying that the yearly exam is good. You know, obviously we're now looking, because we're becoming smarter about pap smears, the HPV cervical cancer, that maybe pap smears, we don't have to test them as often because we're doing unnecessary tests if we do found an abnormal. So you have to have a good discussion with your doctor, but usually if you've had a benign hysterectomy, you've had no history of cervical cancer or any severe dysplasia, you probably don't need a pap smear. But if you have your ovaries, it's always good to have that bimanual. You know, we still do the breast exam. We still are making sure that you are up to date on your breast exam. And, you know, after 65, we start looking at your bones and everything. So yes, we are still saying that we should see you yearly, though the actual pap smear in a hysterectomy, probably not needed. And for women, probably they're saying every 3 to 5 years.
What works for intense cravings on food and gaining weight at core?
I wish I knew. So yes, it's a hard thing. It definitely is. And, you know, a lot of women ask me, should I be on hormones? Well, do you want to take the risk, for that? So, I'm thinking, if you have really lots of increased cravings and everything, there are now new medications to help with those cravings and everything. I use Weight Watchers. I think they're a lovely program. You get accountable and everything. So, but there really is no kind of medication, hormonally that we can use. I don't think there's really been many successful supplements either, because I would be buying them. So, yeah.
The next question is, I've seen blogs recommending vitamin B12 and vitamin D3 and K2 to help with fatigue, exhaustion, and sleeping issues. Is this something that is recommended?
No, it's not recommended, but I mean, all these things, like I said, the FDA, it's not their role to test and verify supplementation. These are new things that are just being studied and looked at and everything. So, I mean, they don't harm, and if they do help, I don't think that there's any reason not to try them. So, I'm a big proponent for that.
The next question is suggestions for GI issues that come with menopause.
GI issues. So I'm thinking, I mean, some women have constipation and everything like that. Just like what colorectal surgeons would say, increase your fiber. There are fiber gummies, there's Metamucil and everything like that. If your bowels have changed, maybe start eliminating some things to see if you have triggers or things like that, and kind of go from there.
Now, I know that we are at time. So, and I'm reading through the questions, and it looks like the most common one has to do with treating joint pain and hot flashes.
Right.
So what would be your recommendation for that?
Sure. So like I said, for joint pain, I think really just using those joints, exercising, muscle strengthening. You can try the over-the-counter supplements for the joints and everything like that, but just to really keep it moving. And then hot flashes, I think you really have to look at, how severe they are. Are you at the point where it's affecting your life and you want to try the treatments that I've discussed? Are you a candidate for hormones? And then if you're not, we've got these exciting new things. So, I mean, really, you can try the lifestyle changes and everything. And then if you get to the point where you're just like, I can't do this, go see your doctor and really kind of have a good discussion and see kind of where you fit and what's appropriate for you. So.
And I know we have a lot of questions, so we're going to go ahead and just wrap it with this one. Is there a test to determine what stage of menopause you are in, or can you get tested to see if you are in perimenopause?
No, there's not a great test. And even, it's funny, even your lab work can look like you're in menopause the month that you're not ovulating. So if a woman comes to me and she hasn't had periods for 3 months and I test her hormones, it may show that she's in kind of a menopausal state. And then the next month that she might have a period. And if I tested them then they might look like she's still in that perimenopausal. So there really isn't anything to tell us, this is when she's in perimenopause. She's got 5 years, because these tests, because like I said, they fluctuate, even monthly they fluctuate. So it's even hard to find, when do we do the test? What cycle day? So there really isn't anything that we have. I know there are some kind of over-the-counter things to kind of that they're kind of touting now, but there really isn't anything. We really do have to go with the symptomatology. Sometimes I like to use family history, but unfortunately, a lot of people's mothers or grandmothers, aunts, they've all had hysterectomies, which kind of, blur the picture. So.
Yeah. Well, thank you so much, Dr. Zakowski. I know that I learned a ton, and I hope that everyone viewing us right now did as well. Again, if you missed the beginning or you just want to go back and rewatch this, you'll receive an email with a link that will take you to the webinar as well as our past webinars. So Dr. Stokowski, thank you so much for being here. I really appreciate it. I hope that you and everyone has a great weekend.
Yep. Have a wonderful weekend.
Bye-bye.
Bye. Ay, ay.